Medurstand. Understanding Medicine.
I am Professor Azizur Rahman, and in our series of lectures on congenital heart diseases, today we are going to discuss right to left shunts. And I think they are also called cyanotic heart diseases. And I emphasized that those conditions which are characterized by left to right shunts, there is no cyanosis, so they are called acyanotic heart disease. But those conditions where there is a right to left shunt, there would be cyanosis, and that is why these conditions are called cyanotic heart diseases. Why would there be cyanosis in right to left shunt? Because the blood on the right side is unoxygenated. If that is pushed into the left side and then goes on to the systemic circulation, that would cause cyanosis. Now, I told you whenever there is hole in the heart, there is always left to right shunt. The reason is that at all levels, atrial level, ventricular levels, or great vessels, the pressure on the left side is always higher than the pressure on the right side. So that is the following the principle of physics, the following the gradient, blood will flow from left to the right. But if there is additional obstruction to the right ventricular outflow, there is obstruction to the right ventricular outflow, only then pressure in the right side can exceed the pressure in the left side, and there could be right to left shunt. So there are a number of conditions where this can happen, and I'm going to discuss them very briefly, but we will only take Fallot's tetralogy, one of the conditions of right to left shunt, in more detail. All we just mentioned just for the sake of completion. Now, this is the heart. Normally right side is coded blue, and blood from the right ventricle to go to the pulmonary artery, and after circulation it comes to the left, and left sided is coded red because it is all oxygenated blood. There is no mixing. But if there is a right to left shunt, so there could be then mixing. First of all, let me just explain that the sequence with which these conditions will appear, they do not reflect the commonness or their importance. I just thought that in a certain anatomical sequence, it will be easy to remember them. So coming from the periphery, first thing which comes in the circulation is the septum, the tricuspid valve. So if tricuspid valve is atresia, that means tricuspid valve does not develop, then blood from the right atrium cannot go to the right ventricle. So the blood will be forced to the left atrium through a patent foramen ovale. So this will cause cyanotic heart disease. Then Epstein anomaly. In this condition, the tricuspid valve is set at a very low level. So functionally, right ventricle is very small and does not function properly. So the blood coming to the right ventricle is not being pumped into the pulmonary circulation in enough quantity. So pressure will build up here again. A foramen ovale will allow blood to go to the left side. Again, there will be cyanosis. Third and the most important condition is Fallot's tetralogy, and there are actually four defects in this, and this is most compatible with adult life. So I think if you see a blue baby or a blue child, a blue grown-up person, it is most likely that that person has got Fallot's tetralogy rather than any other condition, because this is most compatible with uh, uh, adult life. These are more serious, and child is more likely to succumb to this disease earlier in the youth. Then transposition of great arteries. So pulmonary artery arises from the left ventricle and aorta arises from the right ventricle. So of course, if the things are opposite, oxygenation cannot occur, and again there is cyanotic heart disease. Similarly, there is anomalous pulmonary venous drainage. In this case, the veins are attached to the wrong atria. The right atrium drains the pulmonary blood and the left atrium drains the systemic blood. So again, there will be cyanotic heart disease. They're all serious diseases, and child is likely to be born with cyanosis or will develop cyanosis immediately after birth, but in phalangotetralogy typically cyanosis develop after first year of life. Some common features, like I discussed, some common features in left to right shunt. I think equally important is this right to left shunt. Whatever the defect may be in all 4 or 5 listed, the features would be the same. There would be cyanosis. No, that is why they're called cyanotic heart diseases. There is cyanosis because right-sided blood, which is poorly oxygenated, which is actually cyanotic blood, is forced to go to the left and bypassing the lungs. So it goes to the left and then onward to the systemic circulation. So that is why these children have cyanosis. And this cyanosis is central cyanosis. By central cyanosis, we mean that cyanosis is present everywhere. It would be present on the extremities, it would be present on the lips, on the tongue, on the palate, on the conjunctiva, and even if you are looking at the throat or you're doing some endoscopic procedure, every mucosal membrane will also be cyanotic. So this is central cyanosis. I think there will be a separate lecture on cyanosis, so we will discuss some more detail there. Because of chronic hypoxic state, there would be polycythemia. You know, whenever there is chronic hypoxia, there is stimulation of erythropoietin production, and erythropoietin produces RBCs, and that would cause polycythemia and will also cause hyperviscosity because blood is very thick and is not flowing easily. Now, if you have polycythemia, you are more likely to have cyanosis as compared to when you have anemia, given that there is a cause for cyanosis. So these children, they have polycythemia because of chronic hypoxic state, and they will develop hyperviscosity and clot formation. There would be clubbing also because clubbing is a feature of chronic hypoxic state. So these children would have generalized clubbing both in hands and feet. Then there is possibility of early presentation because the mother can detect presence of cyanosis, especially when the child cries, because when child cries, actually it's like producing Valsalva maneuver. So pulmonary pressure increases and that actually increases the shunting of blood from the right to the left. So cyanosis will increase and there may be early presentation and early death also. There may be paradoxical embolization. And what is meant by that? If there is a clot in the deep vein of the legs or pelvis, and if it gets embolized, it will be stuck in the pulmonary circulation called pulmonary embolism. If there is hole in the heart and blood is flowing from the right to the left, this clot can actually go to the left side of the heart and then onward it can cause brain infarction, or it could settle, if it is infected, it could settle in the brain to later cause brain abscess. So brain abscesses, which are otherwise very rare condition, may be seen more frequently in people with right to left shunt. So these are the common feature. They were the common feature which we see in all the cyanotic heart diseases. As I discussed earlier, the commonest cyanotic heart disease is Fallot's tetralogy, and we will discuss this in some more detail. It is called tetralogy because it has got 4 components. It is called Fallots because that was the person, the physician, the scientist who described all these 4 features. So it is named after his name. First, there is ventricular septal defect. Then there is pulmonary stenosis. This pulmonary stenosis is usually not valvular, it is infundibular, and it is also variable. a valvular stenotic lesion would be fixed, but in fundibular stenosis, that means the part of the right ventricular outflow just close to the valve, that is the part which is affected. And since this consists of muscle, it could vary. And sometimes the pulmonary stenosis may be more, and sometimes it may be less. That is what actually precipitates the symptom, and that is what actually determines the prognosis. If somebody has more pulmonary stenosis, that child is more likely to be symptomatic and have complication. Then overriding of aorta. That means normally aorta drains left ventricle, but since aorta is displaced forward, it would be draining both left ventricle as well as right ventricle. You can appreciate this ventricular septal defect in phalangocytology. You can appreciate this in fundibular stenosis of pulmonary artery, and you can also appreciate this overriding of aorta. Like when left ventricle and right ventricle both contracts, both chamber will throw blood into the aorta rather than pulmonary circulation. That is how there is a right to left shunt. And then there is right ventricular hypertrophy, which in a way is actually compensatory, but that is one of the components. So you are likely to see four components in a cyanotic heart disease if this is a case of phalangocytology. Same thing, I think this is a defect, and because of pulmonary stenosis, blood is shunted from the right to the left. What are the clinical features? It is the commonest of all the cyanotic heart diseases, at least in adults, because others would succumb to the complication at much younger age. And cyanosis develops after the neonatal period. There's some mechanism, I personally do not understand it well, but due to some mechanism, cyanosis typically develops after the neonatal period is over. And then a child who may be minimally symptomatic but sometimes develop what is called hypoxic spells or TED spells. Now these are actually spells. These are like attacks of worsening of cyanosis, and sometimes it may be associated with fits and unconsciousness because it represents increased hypoxia. These children are always hypoxic, but during a TED spell, their hypoxia increases. That can cause critical brain anoxia, and that could result in a fit or altered state of consciousness. Then on examination, you would have two murmurs, one systolic ejection murmur arising from the pulmonary stenosis, and other one a pan-systolic murmur arising from the ventricular septal defect. And I think you already know systolic ejection murmur is a diamond-shaped murmur which starts with the first sound, increases in the intensity, becomes maximum in the middle, and then decreases in intensity. It is also called diamond-shaped murmur or crescendo-decrescendo murmur. And pan-systolic murmur is a murmur which starts with the first sound and ends with the second sound. It is of course a systolic murmur, but the murmur is audible throughout the systole and maintains its intensity. Is a pan-systolic murmur. This is due to ventricular septal defect. Since there is pulmonary stenosis as well as VSD in these conditions, so you will have two murmurs, two separate murmurs which are heard on two different areas. There may be brain abscess, I just explained the mechanism, and poor growth. Of course, child would not grow normally, both physically as well as mentally, if the child is hypoxic all the time. So there would be growth retardation. This is the diagram showing the murmur. Now this is the systolic ejection murmur, the diamond-shaped murmur or crescendo-decrescendo murmur, heard on the left side of the sternum and the second intercostal space. In the systole, there is no murmur in the diastole, and pulmonary component is slightly taller because of the pulmonary. I'm not sure. I think pulmonary is not drawn correctly, pulmonary component will be faint in this case. Now, this is the second murmur, the fourth intercostal space left to the sternum. This is pansystolic murmur. Murmur starts with the first sound and with the second sound, and it is of the same intensity. Now, you may not be able to appreciate these two murmurs because both are systolic, but if you're an expert, then you will appreciate that this is best heard in the second intercostal space, and this is best heard in the lower part of the left sternal border, the fourth intercostal space. But of course, a precise diagnosis is difficult, and you may not be able to establish the diagnosis even if you have strongly suspected Fallot's tetralogy. You must confirm this diagnosis by investigation. Of course, ECG and X-ray may be useful to give you some additional information. Blood tests may also be useful, but ultimate in the diagnosis of Fallot's tetralogy, like all congenital heart diseases, is echo. So all these patients must have an echo. Sometime the transthoracic echo may not be enough. Transesophageal echo may be needed to get closer to the heart and to get a better picture. So this is the TET spell. The child becomes cyanotic. You can see the sinuses present on almost everywhere, on the feet, on the hand, on the lips, and this is central sinuses during a TET spell. Tetralogy of Fallot, the treatment, there is no medical treatment. There is either the possibility of palliative surgery or repair. Now, what is palliative surgery? To my knowledge, palliative surgery is not done these days because now we have repair, the possibility of repair. But in old days, they used to do the palliative surgery. But you need to understand what was that palliative surgery. They actually created an artificial shunt between aorta and pulmonary artery because blood is not going to the pulmonary artery from the normal right ventricle because of the stenosis. So some blood must go to the lung to get oxygenated. So they created a shunt from the aorta to the pulmonary artery. So distal to the pulmonary valve, the blood will go to the pulmonary artery, circulate through the lung and will get oxygenated. This would of course put the left ventricle under some volume overload, but will at least make the life possible, which allow the child to grow a little bit, and later on repair may be done. But in advanced center, I think repair is done straight away, and in the repair you correct the actual abnormality. This would be a very complex surgery because we have multiple defects, and I understand that every child may not be lucky to recover completely. I think some residual symptoms will perhaps persist. So this was an account of cyanotic heart diseases. I just mentioned all 4 5s for the sake of completion, but mostly if you see a cyanotic child, a cyanotic baby, a blue baby, it would be most likely Fallot's tetralogy because I said Fallot's tetralogy is least serious of all these 4 5 conditions and is most compatible with growth into adult life. So that completes our cyanotic heart diseases, and in the next lecture I will take up some miscellaneous condition, and that will be the last lecture. I think after that we're going to have a quiz just to let me know how well you have understood the message. This was Professor Azizur Rahman from Medurstand. Thank you and look forward to see you in my next lecture. Thank you.